Okay, great. Thank you very much. So, good morning, everybody. This is the last day of the conference, and it's the first session, 9 in the morning. So, I mean, it's understandable that the room is not that full. And during this session, I mean, you can already see it from the name, Health Facility Profile. We are going to discuss some of the use cases from the Health Facility Profile. First of all, we will have a presentation from An Chu from WHO about the integration of health facility attributes and the importance of the integration of them on the routine health information system. Then we have a presentation from Anu from East Vietnam about their experience on integrating this type of data collection and especially analysis and the use of it in Laos. And we'll have our online presenter, Isabel, from UNFPA, that she's going to talk about their experience on the use of specifically on the childhood and mother health indicators on globally, but as well their experience on Senegal, in which they have implemented in DHIS2. So I will leave the floor to An Chu, and we will have some time at the end of the session for some Q&A. So we'll be really willing to have more details as well about specific questions or any doubts that you should have. Thank you very much.
So good morning. We just go through something, one of the work that is part of the collaboration between WHO, the Global Fund. I'm just so happy that Joanna is here, and the HISP centers on what has been quite popular. And I remember the first 6 years ago, I came with a team of WHO HQ to present this package. At that time, it was about 6 different programs, and now it has evolved into quite a substantial, both in depth in the and also in the broad, in the range, in the breadth of the programs that involved. But I'm just let you pay attention to the middle one, which is the integrated analysis, where we're trying to look at it from the health facility perspective. At national level, but more importantly and unusually is the district level, where we are trying to promote and advocate and support the district managers to look at what are the how is the performance in different health facilities, and what else can support them to make sure that the service that they're supposed to provide are available and ready to provide a service for the clients. So one of the work that, on top of the usual indicator about the coverage, who come to the facility, the ANC, the immunizations, the inpatient, outpatients, we also look at what else is there. And then at the time, we had also the health facility, the harmonized health facility assessment is being developed and started to be tested in country. So we and then with the COVID and everything, so we have the many different way of facility survey was happening, and then the Global Fund asked if we can find a way to streamline and makes it simpler and then make into something, a very extensive review into something more simple. And I'm just going to link that with what Nu is going to present in Laos, because that is where actually we have started it long time ago. After Laos was doing the term called the SARA assessment, service availability and readiness, where we look at all the different requirements for a facility to be able to provide the service that it's designated to do. So it's going to be at primary healthcare level and district level. But then that evolved into later on the HHFA, which is a much more complex, much more comprehensive, with many different modules and covering many different kinds of service. That's the health facility, and here we focus a lot on the primary healthcare and district level healthcare that's supposed to provide. So we'll have a list of almost like a checklist of what need to be to have and need to be done, both in terms of the infrastructure, the equipment, the supplies, as well as the capacity of the healthcare workers there. But then also another thing that I remember the conversation with one of the Ministry of Health, and he said, "Ang, this is nothing new to me about all this fighting. We have done it before. But what happened between the survey, between the reviews? No, how are we going to improve it? And that is something that we need. We do not need to know what is our problem because we know our problem. We know where the problems are. But we are not able to address this problem because we do not have a support for that. And this is one of the things that we started in Laos, and at the same time, because we have a lot of partner support there, and we embedded what I used to joke with John, and we said it is the mini Sarah, but to bring it into something that part of the supportive supervision that the districts that go to the primary healthcare level that are able to use and then to address all the issues. So that was the beginning of the work, and then later on with the pulse survey on the sustain to check on the availability of service during COVID and work with the global funds, and then to see what the harmonized health facility assessment can be done, and then we build it into the now called the facility profile. I'm still struggling because I'm just so used to call it the mini Sarah. But, and this is something that we wanted to not just invest on a very, very extensive, and these are the list of the countries that have reported to conduct the HHFA and have the report available. But Joanna will tell more story of the report that she has seen because Global Fund supported a lot of the work on the HHFA. But then, you spend millions of dollars to do either a atlas or the census of all the facility, or you do random selections. But then after that, what happens? And I think this is where we need to stop, to pause and think, okay, now we know where the issues, what are the common issues, where are the most common issues, and how are we going to address that? And I think this is coming so relevant now with the shortage of funding that is going to be continuing, and we have to change the way we think that, we can keep, implementing surveys and assessments because this is something that, it's very grand and it gives you a lot of comprehensive reports. But do we have the fund to continue and more importantly, to use the data that the review gives us to do something that help the facility at lower, subnational level to do it better? So it's just really nice to see that now it has been put as a part of the routine health information system toolkits. It followed the WHO standards, and we're also trying to put together, on other existing sort of survey like the HARIMS and the other surveys, just to see how we can combine the existing facility-based survey into something simple routinely that the district supportive supervisor can come and do the check and then discuss with the facility and then find a way to improve that and make into something as how do I call it, the part of the checklist. And I think there's a lot of work already going on with the supervisory dashboards and app and things that other agencies also support. So what we're trying to do is just to make sure that this is part of the facility. We wanted to know there is the services that supposed to be provided by the facility. We already have a lot of information about the output of the service, the number of people coming in and all of those usual indicators. But we also wanted to see what else is needed and how we can make the facility to improve the coverage of the service as well. So just a few key information here in terms of what has been included as a part of the the facility profile. So this is becoming one of the package of the toolkits that country can download or can work with the HIPS team to build the capacity and being part of the data use, which is going something that I think there's next week. There's also a workshop on that. So the different way of looking at the facility, the health workforce, the equipment, how it's going to be, the readiness of the services, the infrastructures, all the very typical that done in the support of supervisions, have a report and then being put it aside, and we wanted to make it live, to be something that can be addressed on a regular basis. So these are some of the key resources that we put together for the foundation to develop this package. But then I think the next would be very interesting to hear how it has been implemented, with colleagues from Laos and from Senegal. So I will stop here. I'm just starting these sessions, and will be very interesting to see, how we can discuss this and make this as part of the routine data use, as part of the routine data collections, and see how we can use different data can support this package. So I'll stop here, Stefano.
Thank you very much, Anne. Thank you very much for this first overview. Then, so we call on stage Ano from East Vietnam. It is going to give us a presentation about this specific type of program. I would say not really program, but kind of data and the use of it in Laos. Thank you very much.
Yes, hello. So everyone can hear me? Okay, that's great. So first of all, I would like to reintroduce myself. So my name is Anu Savanawong from HIPS Vietnam. I'm an implementer and data communication officer based in Laos PDR. So today I'm gonna present about my experience of using organization unit profile. So just a little caveat. So this presentation isn't about the app itself. It's not going to talk about a lot of technicality, but it's going to talk more about my experience, the concept, and the impact of me personally using this app in my work, especially in terms of like analysis and for other works, for example, like field supervision. Yep, so let's quickly revisit the problem that we have with the facility. So it's a system of units, not a unified system. So we have a fragmented understanding of where our data came from, and organization unit, as everybody knows, it can be anything. Like for example, in Laos, we have the health center, which is the lowest level of health facility. We have district hospitals, we have district health office, which take care of all the administrative tasks. We have the provincial level, we have warehouses, we have labs. So this creates data chaos. We couldn't accurately compare performance, allocate resources effectively, or even get a clear picture of our national capacity. So we don't know how much capacity our health center is. For example, some health centers have the same volume at district hospitals, but we don't know that. Hence, this lack of standardized hierarchy make national level planning, supervision incredibly difficult and very efficient. Sometimes it feels even random. So our solution to build is to build a single source of data. So we try to build a unified profile for all the health entity that we have in our DHIS2. We also want these two to be integrated into DHIS2. We try not to be too much customized. We try to be as DHIS2 as possible. So this is going to be in one system. So there's no separate hosting or any separate user management, just one master facility list. So this is quite a special case for Laos. So this is our classification system. So we have three classifications. So the first one is the service delivery. So that's where hospitals, health center, labs, and vaccination sites are within. So these are the facilities that would normally reported data into DHIS2. So the next one is administrative units. So this represents the country structure, for example, province, districts, and village. And lastly is the departments or offices, so which are part of the Ministry of Health, for example, the national to provincial offices, also district offices. So let's look at what the org unit profile is being used and in practice. So this app would contain report hierarchy and location of the hierarchy. So I just pick up one of the district hospital that we have in Laos. So as you can see on the top, you can see the reporting hierarchy. So this DH, that's the district hospital, it reports to district health office, which normally situated next to each other. And then this district also reported to the provincial office of Luang Prabang, and then it reports to the national level. And you can see, because this is a district hospital, you can see the village that is within the district hospital. You can see the list on the village list, and there's also a map next to it. You can see the plus sign is where the health facility is, and then the black dots are where all the villages is. This is very useful when I try to analyze family information survey. So we have this survey where we collect data of each village that within that district to see how many people are there, how many new children, how many pregnant wife. Sometimes it's very hard to identify like how many villages is in that district. So this app would help you to identify like the number of the villages, and then you can now cross-check the data to see like how many villages out of all the villages within that district is reporting in the survey. The next useful use case is the app allows us to easily maintain, upgrade, and track changes of organization unit over time across all DHIS2 instances that's in your country. So in this example is Lao PDR. So you can see on the top left, you can see there's a latest fund, and there's also like the history of the changes that happen in that health facility like over time. This is very useful because in Laos, sometimes we don't know that each different province have different types of hospitals. Like this one time I analyzed mother and child tracker data, and we found out that in this district, the district hospital type A didn't report anything. So I went in, I checked, and just found out that that province never have district hospital type A. They only have type B only. So this app is very useful for me to go in and check, and also to confirm with the health program to see that, oh, is this the right, correct information or not? Why is this province doesn't have type A district hospital? Is this correct information, or should I change it? So this is a very good function that we have. And also in the app, we also, as I mentioned before, we unify all of the data into one profile so that we can analyze and make decision-making in one place. So apart from what I've shown you, in the app itself, we also contain many data in one place. And this data is being pulled from all the DHIS2 instances. So one of the data that we have is the infrastructure data. This is quite a straightforward data, like total beds, total laptop, and how many vaccine fridges that each health facilities have. So this data ensure operational readiness of each health facility. We also have data of staffing levels. This data can come from any surveys that our partners did, and then we put it into this health facility profile, is to monitor the counts of doctors, nurses, and midwife. So this data will help us to easily optimize the staff support for the efficient care. Next one is the service delivery. Personally, I found this very useful. We have this page to show like what delivery that this health facility provide. Some health facility doesn't provide ICU. Some facility doesn't provide mobile vaccination. Some facility doesn't provide STI. So this page will show us like the data to ensure that each health facility is provide the correct services so that data analysts like myself can understand. I can give you an example where I found that this health center never report data on ANC, and then we just found out that because they don't have maternity ward. So that's why it's quite obvious that they don't have the mother and child data because they don't provide such service. And lastly, this is the key performance. I believe everybody have this in their DHIS2 instance. Key indicators like number of deliveries, number of IPDs, number of vaccinations. We also pull this data into the health facility app. This is because when you compare this to the staffing level, you will see the proportion of how much of the workload of the staff compared to the key indicators. I just found out that this, as I mentioned before, there is this one health center in one province in Laos that provide the same volume of staff as the district hospital. But because they are a health center, they don't get enough people, they don't get enough support, they don't get enough money, they don't get enough equipment. So this is a very good thing, good insight that we can find, and then we can report it back to the higher ups, to the center, to see that, okay, this health facility, the volume is too high. Maybe you should do something about it. So in conclusion, this one single profile of health facility give us a new way of working. It gave us better questions and better insightful data. Next one is target investments. As I said before, sometimes resources are very scarce in Laos. Like we cannot provide the same amount of resources to all the health facility in Laos. So this app provides us the opportunity of target investment to make all the investment as efficient as possible. It's also foster collaborations. As I said, we have a number of staff, we have number of equipments, we have key indicators in one place. So many health programs can look at this profile and work together. And lastly, it gave us a faster response since every data is in one profile and every data is updated live. So you can have rapid actions based on the data that we provided. Yep, so that's the end of the presentation. And again, as I said, this presentation is all about me providing the experience of using the app. If there's any questions on technicalities, please let me know, and then I will pass through to my developers to answer your question. Thank you.
Thank you very much, Arno. And without further ado, we leave the floor to Isabel. She will be unlikely she didn't have the possibility to come directly to the conference, so she will be presenting online directly from Senegal. It's a little bit early there, but she has been very keen to present. So yeah, Isabel, the floor is yours.
Thank you, Stefano. Thank you. Good morning, everybody. I hope that you are hearing me.
Yeah, loud and clear.
Okay, thank you. I'm going to share my screen. Okay. So thank you very much for giving me the opportunity to share this experience. And also I'm very happy with this. I'm Isabel Morera, excuse me. I'm a member of the UNFPA MHCF team from HQ, but based in Dakar. So I would just like to say before I begin that we are very happy to have this new collaboration with the University of Oslo. And this is really part of the what we aim to do all together. And this partnership fits perfectly with our UNFPA new strategic plan and the family planning strategy to support evidence-based integrated country-owned data systems. And our area of collaboration is important. And one of them is together, particularly for e-monk monitoring. I'm going to share one example from Senegal that we would like to build on. And also MPDSR and routine and also routine monitoring and for contraceptive, etc. This is the area of collaboration UNFPA aim to develop with University of Oslo. Okay, I'm going now to share this experience in Senegal, where we have tried unified support integration of emergency care indicator into the DHIS2. As you know, I don't know who is the audience of this meeting, but emergency obstetric care is specific care for management of obstetric and newborn complications that could lead to maternal and newborn deaths. That means we call them signal function. That means it's different level of care depending of the level of the facility. But just to give you a simple example, a basic care could be management of postpartum hemorrhage, which is the main cause of maternal death at basic facility level, until C-section, which is a more comprehensive care at hospital level. Those are the emergency obstetric care, and there are a lot of some indicators have been developed since early 2000 at global level. So those indicators are tracked within the DHIS2. So quickly through the e-monk process in Senegal, because Senegal has worked in the e-monk since early 2000, let's say, some kind of, and it's a long experience with emergency obstetric and newborn care. I'm going to share how data have been collected through the DHIS2, particularly the tool, the DHIS2 platform, and the sheet that have been introduced into the DHIS2, and also some concrete example challenge and some screenshot, because it could be interesting to see how it looks like into the DHIS2. So as I just mentioned, Senegal has done several need assessment, have set up a new monk network based on the fact that every facility cannot provide all those care, basic and comprehensive. A new monk network have been set up, identifying facilities that should provide basic and comprehensive care, and using also access mode to deal with the macros of population with some other criteria. This e-monk network have been set up with 142 facilities. Some of them provide basic and other comprehensive, as I just mentioned in all the regions. So the most important challenge was how to monitor the situation of those 142 facilities in order to see exactly regularly what's going on there, who is providing the care that they are supposed to provide, and what are the challenging, and where are the indicators. So, and this is just to show you the map, that the accessibility map, because accessibility is a key when you are talking about emergency care. We have this travel time is key. The referral delay is also important, because we are talking about emergency. If woman didn't arrive on time. So with access mode, we have this travel time and this coverage of the population, depending on the travel time and the travel scenario and the geographical condition. And I'm showing this because it is also something that we are collaborating with University of Geneva with this access mode, and we are trying to link now. This is our next step, to link the access node with the DHIS2 to have data from facilities until maps of accessibility. That is something that we are working together. What have been done in 2019, which was important, that to have this, how to implement this EMONG network and how to monitor it. We have this data collection sheet I'm going to show you right now. And this document have, and also who is supposed to do what, how to organize this data collection, this monitoring, how to organize this monitor of the EMONG network. And the next step has been to integrate it into DHIS2. That form that I'm going to show you right now have been configured into DHIS2 and linked with each of the 142 facilities with validation rule that you all know. An indicator has been generated that should be generated by DHIS2 have been agreed upon, and also the report format with indicator. This has been implemented in all the 14 regions of the country since 2020. This is just to show you that several stakeholders are involved, from facility level to regional level, regional mean provincial level, to provincial level, and also to central level. Each of those stakeholders have a role, from data collection at facility level, entering data into DHIS2, quality control and report elaboration, and also problem solving from facility level to national level. Here's how it look like the first version of the sheet. It was important to have a simple sheet, 2 sides, and the minimum information needed specifically for readiness of the facility, meaning key drug and supply availability, key material and supply to perform those signal function that lead those signal function, meaning those specific care to manage complication for maternal and newborn, for mother and newborn. Also the minimum basic infrastructure, and this is for readiness. And after that, you have all information about statistics. That means number of delivery, number of complication, number of maternal deaths and newborn deaths, complication managed, referred, and last but not least, the availability of the signal function. I'm talking about the signal function. That means administration of antibiotic, for example. Those are the functions to live with maternal death. This is the sheet, and now based on that, we have this indicator. One of the most important indicator was availability of functioning people. When you talk about basic emergent optic care, functioning basic emergent optic care facility, that means facilities that are performing a basic care as required. That means with minimum number of HR, human resource, 24 hours, with all drugs and supply available 24 hours, equipment needed, the equipment needed 24 hours, functioning equipment, and also case managed during that period of time that the facility had been monitored. So the ability that you can see that it's really a challenge, but this is what is needed in order to provide care and save women's life. So you have availability of functioning BMONG, availability of functioning CMONG, and also availability of all other readiness in BMONG and in CMONG equipment. Also a percentage of facilities that have the required human resource. So according to national law, because in this network, it has been decided that a basic facility should have at least a minimum of this number of midwives, at least 3 number of midwives, depending on the case load. So for doing this monitoring, we have been able to track in a regular basis the number of facilities that have the adequate number of midwives, of OBGYN, anesthetists, because you know that we are talking about emergency and obstetric care. Those other indicators are generated, the C-section rate, but this is not something that is specifically linked to the monitoring, because this is something that was used to be collected. It's just a link that had been done with another form that was already collected in the DHIS2, but that in the EMONG side and the maternal health side, kind of. Delivery rate in the EMONG network, case fatality rate, interpartum, and early neonatal deaths. But also other indicators are followed because EMONG is not a standalone strategy, it's an integrated care. So other care, maternal and newborn services are also monitored. You can see family mother care, but this is just the proportion of facilities that are providing, yes or no, this facility that is collected. Okay, just to show you, because we don't have enough time to share everything, but for example, this is something that was important to show that availability of functioning IMO facility, BIMO, basic and comprehensive, from 2020 to 2023. I just take the Q1 first quarter of these four years, and you can see that it went from 9 to 23 and fall down again because it's challenging to get all the human resource, as you can imagine, in those facilities and having all the drug, because it's really something that is tracked. You need to have all the required human resource. If someone went out, leave the facility, or the facility is no more functioning because there's not enough provider to provide 24-hour, etc. So those kind of challenges that people are facing, but it's important to have those data and to give response, to react. This is an example from the region that is doing the most regularly monitoring. This region is doing monitoring every quarter since 2020, and you can see how amazing those results have been. The case fatality rate having reduced, having divided by 2 or 3. The number of newborn, deaths have been also reduced by 2, and the stillbirth, the evolution of stillbirths also have been reduced. This is we had this peak. It was during COVID, but globally it's reducing. This is just to let you know that with data, people can take decisions. What's happened in this region? Because having this data regularly, they have been able to improve the referral, to better coordinate, to manage drugs and supply, and to distribute drugs when this facility don't have they know the situation and they can share the drug, etc. This is just to let you know that with data, people can react and reduce maternal and newborn death. The challenge the country are facing has been to cross-check information. As you know, saying that a facility is functioning means that those criteria I just mentioned, human resource available, drug supply available, etc. If this computer people, but they have been able to do it, but it has been a long journey. Regular monitoring also in some provinces are challenging, as you know. Sometimes also we face some strikes, and in Senegal, which is a pity. People used to do the retention of data and don't put all the information in the system. So readiness, as I just mentioned, is challenging because it's all these criteria. They face also some technical issue with DHIS2 when the DHIS2 is updated. It took their time its impact based on the information I get. Okay, so as I just mentioned, next step will be to link access mode to calculate this target for indicator, which is the population covered by functioning IMO facility, an indicator that we are supposed to track, the country are supposed to track. So having this data from the DHIS2 and access mode, we can have the population covered and also have maps of coverage, this kind of map I showed you. Now I hope that it's not too long for my side. Just to show you some screenshot, when you open the DHIS from Senegal, this is how it works. This is one of the hospitals of the region that is supposed to provide CMO, comprehensive emergency care. When you have this network and supply, and you have to you see the result of yes, no availability. You have also the equipment, human resource. This is for the entire also equipment extra, but I would like to show you the IMO signal function, availability of each of the signal function, and yes or no, and you have also the reason why it has not been performed. You can have that reason. This is due to equipment or supply that lead to this. This function has not been performed because they have issue of antibiotics, the issue of drugs. You also have this report that is generated. You have this dashboard for for that province, the first quarter of 2021, you have the expected complication. You have this is information that is that they can have from other sources, as I just mentioned. This report 20 with expected birth and C-section. This is kind of report at provincial dashboard. You also have this kind of table of indicators you can have for each province. Yeah, we can have those indicators of unmet need, the indicators that I just show you, case fatality rate, etc. You can also have this dashboard. This is a dashboard for completed the facility that have filled the DHIS2. You can have the expected report and the actual report. This is to have the reporting rate. And this is also another kind of table that is generated with the for the region, where you have the kind of summary of all the number of designated facilities, the number of facilities that are functioning effectively among the. This is a national. You have all the region. You have the number of designated, number of functioning, etc., etc. This kind of report that are generated by the DHIS2 as it is. I think it's time to so much for listening to this presentation. Over to you, Stefan.
Great, thank you very much, Isabel. And so now we have some time left for some Q&A for the ones that are in the room, but of course for the one that as well are online. Maybe, and I think if you like to share some thoughts about what has been presented as well. From my side, what I would like to share as well is we have started to work on this and try to gather more information about this health facility profile, the attributes of the different health facility 2 years ago through a project in collaboration with the Global Funds. And there is one aspect that was present in all of the different presentations, that the power of this type of information is not just on the collection, but it's really in the use and on the triangulation with this information from other sources. We have seen the case on Laos, in which, they are collecting all the information related with the attributes of the facility, that then they are using together with the information coming from IPD consultation, volume of activities, and distribution of activities. But as well here on Senegal, that was shared by Isabel, is really related to this type of analysis. So it's not only to be able to have this type of information, but is on the way how we are going to use this information. So maybe, Anna, I don't know if you would like to add anything else.
I would ask Joanna to have some of her overview, because it was very interesting when Global Fund approached us and said, what about doing this as a way of continuity of the service rather than a pulse checks on the assessment. So before I'm just sharing some of my observation and start a discussion, maybe I can pass on to Joanna for now. Thanks, Joanna.
Thank you very much, Anne, and thank you for the great presentations. So as Anne mentioned, the Global Fund has been supporting SARA implementation, the development of the HHFA, the implementation of the HHFA in many countries. And we have just witnessed a lot of challenges. First of all, it's prohibitively expensive. There are countries that take over 2 years to implement an HHFA. We have recently seen 2 country reports. One was 500 pages, the other was 700 pages. I don't know about you, but that's something I would not even look at. So long list of recommendations and very little evidence that the results are actually being used. We see some countries that are still in the course of implementing such surveys, and they already ask us for funding to implement the next one. So no taking a step back and thinking about, well, we need to do something about it. We need to implement the recommendations. Also, we have done independent quality assurance of these surveys in many, many countries, and systematically there was very poor data quality of the data that was collected. So all of this together, we thought, well, there need to be better ways on getting some key data, not the whole wealth of what, of course, is in the HHFA, but key data that can help the countries to improve the services, to have more efficient use of resources and target, as was well elaborated by the Laos presentation, the resources, discuss resources that are available. And that's behind the idea of this health facility profile. I think it was piloted in several countries. We still think it's a good use of resources to think about its implementation, to give you the key data to improve the service provision and good quality of service provision. Now, I know, Anne, that you have some reflections, but maybe since I have the mic, I would have a question for the Laos colleague. I was wondering how you collect the data before you enter it into your org unit profile, and at what level the data entry is happening. Thank you.
Yeah.
Just on the Laos side, most of this data was not directly entered in the app itself, because this data was collected either routinely in the routine health information system or in other survey. So we didn't wanted the people to just like try to collect the data again, but like the access was once you have all this data, because like we also have a survey data which is done by WHO along with one of the partner, where they did all the service availability mapping, and then we just say, okay, like this is too expensive if you try to do that one. So anyway, this has been done. So we imported that one so that we can give access to the healthcare worker in the facility and in the place where they can update and add on more. So like we don't want a country to just recreate all this information again and again. So one of the things is we took the data from either from the routine health information system, either from the survey which has been collected in different places, and then we combined everything into one places. So the whole effort is to not to reinvent the wheel. And sometimes most of the donors and partners, they want to do the assessment. I just say like its assessment is already been done. Please have a look around here. And then we also made it as a publicly available. So these are all the features which is there. So anyone who comes around for Laos, they can actually look what has been already been done.
Hi. You said all the data, all the data is available for public. Is it easily usable by the public, like to find out which facility is nearer to them and which ones provide a specific service?
Actually, like if we, what we deliberately did is to try to pull what we call a public portal. It's HMIS.go./data. So that gives you the list of all the data, what's available in DHIS2 and in other places. We talked with the Ministry of Health so that it's available for the public. And the facility profile, we don't really know what is closer, but like they can just still see in my district what are all the health facilities and what kind of services they've been providing. So it's available.
Thanks, John. Any comment and feedback from the audience? Just also my observation as well is this is a very good way of emphasizing and also mobilizing the functions of the supportive supervisions. And actually, because they normally you see the supportive supervision, they go to the facility, they do the task, and then that's it. But there's very little of the follow-up. And by having this tool, and I think that it's really nice that we have all the standards and the requirements that's in the list, and then you use it as a guide for the supportive supervisions. But then this is also a very good way of trying to bring in different type of support. So Isabella was talking about, the special support on the maternal and child health and MOC. Other would be on immunizations. Some would be on the usual maternal and child health or surveillance. But the point is that different partners in the countries, including those who are local partners at district level, can also help. So instead of having different activities that managed by different projects, this would be the way for the district and the provincial or the regional health authority to use it as a tool to coordinate of the support. And I think another example of Lao was actually the World Bank was of the agency that support for making sure that all the life-saving commodity is available if there is a running out of stock by the end of the support supervision. So these kind of things are really important because the health facility will realize that, they need to check on that in order to ensure the facility and the services. And the manager also realize that, it's important because they can use it as a way of mobilizing the resources and the supports and put it all on the same plan. And I think this is something, the value of the facility. Maybe you can put it on my... And then one more thing before I pass on the floor to Stefano is the use of the data on different reporting streams. Normally, we only look, if we are working on MCH, we only look at MCH data. If we are looking at TB or HIV or malaria, we only look at our program data. But the power of bringing data and seeing the entire service needs in the facility through the outputs of the data. So just as some of the key to say that, out of all the health facility in the country, these are the standard dashboards that's available on our demo site, right, Stefano? But just to look at of all different services in the country and see what are out there the services. A very good example that Nu said is if the one health facility have exactly the same volume of patients coming in as the next, and I remember that, and later on I found out that because there was a mountain between the two facilities, so one has twice the number of patients than the others when they have the same amount of staff. So those kind of things we can spot it, and then it will be able to help because we would know the number of staff, the kind of skill set that provide for the services available, and we can look at across all different services that provided by the facility. And then the manager would be able to talk to different programs that provide the service to make sure that all the essential equipment and everything that is required for the service is there. And this is some of the key examples that you can have a look at that at the website, but then also we can discuss. And I think what important is to look at to work together with the programs as well and see how best we can make sure that we have a stable flow of data and supplies for the service in the facility. So I'm just wanted to run through this and then I'll pass it on to Stefano. And this, I think, is on the demo side of the routine health information system toolkit. So I'll stop here.
Thank you very much, Anne. Thank you very much for the presenter as well to Joanna for the participation. I don't know if there are any other questions in the room or online. Okay.
I think there is next session is on Joan's sessions, right, Joan? On the facility check app. So this is linked to how you're going to work on this and get the functions in the DHIS2.
Exactly. I will be in auditorium 4 and it's very linked to this same topic. There will be presentation from I think as well ISP Vietnam from that and this type of use case. So I think we are very on time for one time. So I just would like to thank you for your participation. In case you have any further question, please feel free to reach out to the different presenters or to myself. We'll be very happy to answer to all your questions. Thank you very much.